Anna Collins. Anna Collins was an ST6 with us ST3 with us previously. She's now our subspec trainee. She went off and did a PhD in Leicester in a research in endometrial cancer. She also holds a position with the International Society of International Board of Gynae Cancer. Sorry, Anna. I'll hand over to Anna.
Fantastic. Okay, so brilliant. So everyone, welcome to the Delta Gynecological Cancer Symposium. So I'm going to deliver the first talk today just on an introductory talk to endometrial cancer. And I hope this just serves as a flavour of the topics that we'll be covering in more detail later on in the day. So what I'm going to talk about is epidemiology and cancer statistics for endometrial cancer, the clinical presentation, the diagnostic workup, staging, and then the primary management. So endometrial cancer is the fourth most common cancer in women in the UK. Since the 1990s, the incidence has risen by 59%, such that now 1 in every 39 females will be diagnosed in their lifetime. But about a third of these cases are believed to be preventable, and modifying risk factors therefore becomes really important, particularly managing obesity. And we're getting a fantastic chat later on from Dr. Sarah Kitson about obesity and endometrial cancer. Endometrial cancer is often diagnosed at an early stage and has excellent long-term survival outcomes. So up to 72% of women will survive uterine cancer for 10 years or more. And this is important because we need to consider the long-term survivorship and the issues that women face living with a cancer diagnosis. Finally, about a quarter of new cancers are diagnosed in women over the age of 75, and these women also experience the highest mortality rates in relation to the disease. So it's incredibly important to manage comorbidity and frailty optimally in women with endometrial cancer. So how does it present? Symptoms of endometrial cancer, typically in the postmenopausal population, are postmenopausal bleeding. And there's a probability of endometrial cancer is about 9% for women who present with postmenopausal bleeding. But this is age dependent. So in women over 70, the cancer risk is about 50%. Other things to note is that if you have unexplained vaginal discharge or hematuria, or high platelets, NICE actually recommend that women over 55 have a transvaginal ultrasound as part of their workup for that. And in the premenopausal population, persistent intermenstrual bleeding or heavy menstrual bleeding, which is refractory to conventional treatments, particularly in women with risk factors for endometrial cancer, is important. So your risk factors are hypertension, diabetes, obesity, and then prolonged exposure to unopposed estrogen, so things like polycystic ovarian syndrome and tamoxifen. Advanced disease can present with bloating, abdominal distension or pain, and altered bladder or bowel symptoms. So what this chart shows you is the route to diagnosis over time from 2006 all the way through to 2018. And the dark blue line shows the number of cancer diagnoses via the 2-week wait pathway. And the pink line is standard GP referrals. And I think this is really important just to highlight, the fantastic work done by our primary care colleagues about recognising risk factors and referring patients inappropriately. And your other presentations, so your kind of inpatient reviews and emergency presentations, have tended to remain static over time. So is it possible to detect endometrial cancer in an asymptomatic general population? Unfortunately, we don't have any current evidence that screening asymptomatic women with transvaginal ultrasound or endometrial sampling improves outcomes. However, specific populations can benefit from screening, so particularly women with Lynch syndrome. This is an inherited cancer predisposition syndrome, which affects the DNA mismatch repair system. And in terms of gynecological cancer, women are at higher risk of early onset womb cancers and a 10 to 17% risk of ovarian cancer. So you can, according to the BGCS guidelines, offer these women screening with transvaginal ultrasound and then endometrial sampling or hysteroscopy annually from age 35. And they can be considered for risk-reducing surgery, which would be hysterectomy to reduce your risk of womb cancers. And then if they wanted to also reduce their risk of ovarian cancer, risk-reducing BSO. We're going to be getting a much more detailed talk about Lynch syndrome and genomics and endometrial cancer later. Tamoxifen users should be counselled that if they have abnormal bleeding, this should be investigated. But tamoxifen can cause hypertrophy of the subepithelial stromal layer, which can interfere with endometrial signallings. But it's important that bleeding is investigated for those women. So in terms of your workup, your history should include, full evaluation of the presenting complaint, so the timing, the frequency, the intensity of bleeding, and then a complete gynecological history and past medical history to look for risk factors of the disease. And it's important to look at people's BMI, their comorbidities, any previous surgery, any fertility desire, frailty and performance status, because that's going to help you plan their care. And all women should have an abdominal, speculum and pelvic examination. So our first line investigation would be a transvaginal ultrasound, and we do a double layer endometrial thickness measurement. And an endometrial thickness of less than 4 millimeters in a woman with postmenopausal bleeding has a very high negative predictive value for excluding endometrial cancer, which is over 99%. But it's just important to remember that the diagnostic test accuracy of ultrasound is lower in Black women because of the high prevalence of fibroids and the higher risk of having a non-endometrioid cancer in this group of women. If you take HRT, a cutoff of 5 millimeters can be used. And in terms of asymptomatic postmenopausal women, if they incidentally have a finding of a thickened endometrium, you can use an upper limit of between 8 and 11 millimeters, but the BGCS guidelines are for 8 millimeters. You should look for any focal abnormalities, things like cystic spaces, feeder vessels, fluid in the cavity, because these can be suggestive of endometrial polyps. So your definitive diagnosis will be via histological sampling, which can be done via a PIPEL. But a hysteroscopy and directed biopsy would be indicated for premenopausal women, unless this would delay your diagnosis. If outpatient biopsy is not feasible or you have non-diagnostic sampling. If you see any focal abnormalities, so in terms of polyps, there's a prevalence rate of 6% of hyperplasia and atypia in women who have a normal background endometrial biopsy in polyps themselves. So polypectomy should be considered in that setting. So all women with endometrial cancer should be discussed at a specialist gynecological cancer MDT, and then treatment should be planned depending upon individual risk factors. So the comorbidity, the frailty, any fertility wishes, the size and extent of the tumour, and a plan for the route of surgery may need to be made looking at what previous surgery they've had. And all women should have an anaesthetic assessment. Enhanced recovery and prehabilitation also have a role in the pre-optimization of women for surgery. All women should have chest imaging to exclude pulmonary metastasis. An MRI pelvis is useful for assessing local regional spread and myometrial invasion. And CT should be done for women with high-grade disease, deep myometrial invasion or non-endometrioid subtypes. So the ESGO endometrial cancer guidelines define 4 different prognostic risk groups, and this is based on traditional uterine and the newer molecular features. And this classifies endometrial tumours into low, intermediate, high intermediate and high risk disease. And the sort of prognostic variables that we look at that are associated with poor prognosis are things like non-endometrioid subtypes, so serous, clear cell, carcinosarcomas. High-grade disease has a poorer prognosis, as well as advanced stage at diagnosis or substantial lymphovascular space invasion or lymph node involvement. And it's really important to understand how these uterine prognostic factors determine tumour behaviour. And then your adjuvant treatment is dependent upon these risk category groups. So let's talk about the molecular classification. This has now been well integrated into risk classification systems and also international guidelines. And this was built on a practice-changing study from the Cancer Genome Atlas Research Network. And what they did was they identified 4 different molecular subgroups, each with a distinct prognostic outcome. And they've then developed a pragmatic classification system which uses immunohistochemistry to look for MMR and P53, and then Sanger sequencing to look for polymutations. And this enables us to stratify women into different molecular groups. So for the polymutant group, which is about 5 to 10% of endometrial cancer, this is a group which has the best prognosis, and there's opportunities to potentially de-escalate therapy in this group. Whereas your MMR deficient group, which is about a third of tumours, there's a loss of mismatch repair proteins, and there's a potential role for immunotherapy in this group. Whereas your P53 mutant tumours have the poorest prognosis. In this group, they're looking at the role of things like PARP inhibitors. Whereas your non-specific molecular profile group, they have a variable prognosis. And in this group, particularly looking at the uterine prognostic factors, is really important for determining outcomes. So the studies that are upcoming that's going to really help with us in terms of defining our adjuvant treatment strategy is the PORTEC-4A and also the Rainbow Trials group. And this is what I've just got on the screen. You can see the figure. It just says the different strategies which will be considered, and we'll be hearing more about this later. So we had a big change in the FIGO 2023 endometrial cancer staging this year. And what this attempted to do was to reflect our improved understanding of endometrial cancer tumour biology, and it incorporated uterine and also molecular prognostic factors, kind of moving away from a traditional staging which looks just at extent and spread of the disease. But there's been some recent controversy about actually implementing this into clinical practice, and the reason for that is that although the prognostic variables are established, we haven't defined their impact on how we treat people, which could, impact on our abilities to counsel patients. In terms of a global classification system, not everywhere has access to molecular classification, and this could certainly impact upon global research. And there's also some concern that the standardized interpretation of some of these factors, things like LVSI, is different amongst different pathologists, which may interfere with individual cancer staging. So in terms of the primary management of early stage disease, your standard surgery would be total hysterectomy and bilateral salpingo oophorectomy. A mental biopsy can be offered for non-endometrioid subtypes, and ovarian conservation is an option for premenopausal women with grade 1 endometrial cancer with less than 50% invasion. In terms of route of surgery, we've got good evidence from a Cochrane review that there's no significant difference between open and laparoscopic surgery in terms of cancer survival outcomes, but there is an improvement in morbidity with laparoscopic surgery. In terms of robotic surgery, this also appears to be non-inferior in terms of oncological outcomes, but long-term outcomes are lacking in that setting. But robotic surgery may have a particular role for helping with the surgical management of women with high BMI. In terms of lymphadenectomy, lymphadenectomy is a diagnostic procedure, and performing a systematic lymphadenectomy has not been shown to improve survival or reduce the risk of recurrence, but you can offer surgical staging in women with higher than low risk disease. And sentinel lymph node mapping, where the first draining lymph node in the regional basin is sampled, is an alternative strategy with higher diagnostic test accuracy and reduced morbidity. And we'll be having a whole talk by Dr. Jo Morrison on lymph nodes later on. So managing advanced endometrial cancer is very complex. There's a variety of potential treatment options, and decisions should be individualized. So there is a survival advantage associated with surgical cytoreduction, but we don't have high quality data in this setting. But cytoreductive surgery can be considered to remove all visible disease if it's considered feasible with acceptable morbidity for the patient and quality of life. The aim is to achieve complete clearance of the disease, and that has been shown to be a survival benefit ranging between 9 to 15 months. We don't have any prospective randomized controlled trials for the use of neoadjuvant chemotherapy and interval cytoreductive surgery, so our evidence is based on small retrospective case series. But you can consider neoadjuvant chemotherapy, which is usually carboplatin and paclitaxel, with response rates of 76%. And around 4 out of 5 women will end up undergoing interval cytoreductive surgery, with about half of these undergoing and achieving a complete cytoreduction. There is a role for palliative surgery in terms of controlling symptoms, and this should be an individualised decision. Carboplatin and paclitaxel are your standard of care first-line chemotherapy options. And endocrine therapy is another option for advanced low-grade hormone receptor positive disease, and this is generally pretty well tolerated because it's got quite a low toxicity profile, so it can be useful particularly for women with frailty or lots of comorbidities. And you could consider medroxyprogesterone acetate, or then tamoxifen and aromatase inhibitors can be used in women who have quite a high risk of vascular complications associated with high dose progesterone. We've got lots of targeted therapies that are currently being investigated, and Dr. Andrew Clamp from the Christie Hospital will be talking about this later on in the symposium, so I'll save that for Dr. Clamp. In terms of women who are medically unfit for primary surgery, they should have an individualised management plan. You can consider vaginal hysterectomy potential under a spinal anaesthetic, which is likely to be curative for women with low-grade and early-stage disease, which is a potential option. You've also got the option of progesterone therapy, as I've mentioned before, and also definitive pelvic radiotherapy, but recurrence rates in this setting are about 18%. So if women do desire fertility, and it's important to note that there is a rising incidence in young women with endometrial cancer, you can consider a fertility sparing approach for women with atypical hyperplasia or grade 1, stage 1A endometrial cancer. Any woman being considered for fertility sparing approaches should have an MRI scan, a specialist histology review and discussion at MDT, and also a referral to fertility to look at their baseline chances of success in terms of their fertility options. In terms of management, you can have oral progesterones, the Mirena coil. The advantage to Mirenas or IUDs is that it can deliver high concentrations of progesterone with fewer systemic side effects, and it also ensures perfect compliance. And you can have combination therapy, including GnRH analogues and hysteroscopic resection. In terms of success rates, the overall success rate is about 76%, with 25% risk of relapse and about a 25% risk of achievement of getting a live birth. So that's just important for women to know. In terms of our adjuvant treatment, it is dependent upon the risk profile. So low risk endometrial cancer is not usually offered any adjuvant treatment. Brachytherapy can be considered for intermediate risk endometrial cancer, but it can also be omitted, particularly in younger women. In high risk or high intermediate risk endometrial cancer, you can have brachytherapy and also external beam radiotherapy. And then in high risk endometrial cancer, the PORTEC-3A trial showed an overall survival benefit of 5% and a progression-free survival benefit of 7% for women having external beam radiotherapy with concurrent cisplatin and adjuvant carboplatin and paclitaxel. So there's a role for both radiotherapy and chemotherapy. This just touches on, this is from Cancer Research UK, what sort of treatments people are receiving dependent upon the different stages of disease. So the light blue is surgery only, the yellow is surgery plus radiotherapy, the purple is surgery, radiotherapy and chemotherapy. And what you tend to see is that in early stage disease, stage 1 and 2 disease, the vast majority of people are treated with surgery plus or minus some radiotherapy. But when we look at our stage 3 and 4 disease, there's much more variation about what types of treatment people are receiving. And particularly important is if you look in stage 4 disease, about a third of women are kind of falling into this grey area of having other care. And I think it's really important to actually try to work out what care these women are receiving, if they're being offered treatment, and if not, why, to see if we can improve outcomes in this setting. So the aims of follow-up are to detect treatable recurrences. The options for treatment are salvage surgery or exenteration, radiotherapy if they're radiotherapy naive, and chemotherapy. There's definitely a role for patient-initiated follow-up and self-supported management. If patients are having this, they should have a treatment summary at the end of their treatment with the cancer nurse specialist, and there's an important role for that. And just cancer survivorship is hugely important. So it's not just the oncological follow-up which we need to do. We need to be very holistic about women's needs, and remember that women will live for potentially up to 10 years and be this could have curative treatment for endometrial cancer. So we need to look at the physical, the psychological, and the treatment-related side effects, and make sure that we're treating these optimally. And then it's important to recognise progression of disease and when women are reaching end of life associated with endometrial cancer. And we've got a talk planned on palliative care in this setting later on. So just to conclude, endometrial cancer is a disease with complex tumour biology. We're really starting to understand this in a lot more detail, particularly the prognostic variables and how these can impact on our adjuvant treatment strategies. And over the next 10 years, there's going to be huge opportunity for innovation, both in terms of surgery, but also in terms of targeted therapies. And what I'd really like to see us getting more information and more evidence for is how to optimally manage advanced disease. I think it's important to always take an individualised approach and make sure that you are thinking holistically throughout the whole patient journey from diagnosis to follow-up, because you'll see a huge range of women presenting with endometrial cancer. So thank you so much for listening. I'm very happy to take any questions, and I hope that gives you a flavour of things to come.
Thank you, Anna. That was a fantastic talk and set the day out perfectly well. I'm sure we'll all agree. Has anybody got any questions at all they'd like to ask? Any hands that are raised? Susie, any comments?
No, well done, Anna. That was a great talk. I suppose I'll start with a question. So postmenopausal bleeding is one of the commonest referrals that we'll get in via the 2-week wait pathway from GPs. So and we know that our 2-week wait pathways nationwide are overwhelmed. So can you think in terms of service development, anything that we might be doing or that we could do to try and sort of address this and try and reach the targets that we need to reach, particularly thinking about that postmenopausal bleeding cohort?
Yeah, so I think particularly there's definitely a role for kind of ongoing primary care education and confidence. If they get the scan, if we can get faster diagnostic and faster scan pathways, there's a role for diagnostic hubs and things like that, so that we can get rapid reporting, and then just giving people confidence and education for knowing that if it is less than 4 millimeters with no focal abnormality, they don't necessarily, and you've done a speculum to look for a normal cervix, they don't necessarily require a referral. So I think there's some things that we can do to make more robust pathways there. The other thing is that just knowing that not all women will need a hysteroscopy. So certainly you can use Propel biopsies. And the BDCS guidelines actually say that as long as you've put the Propel more than 4 centimetres through the cavity, in that setting, even if it's inadequate, as long as you're happy and the woman doesn't have recurrent bleeding, you can accept that. So I think that's a way that we can sort of streamline investigations as well.
Yeah,
fantastic. Saba, would you like to unmute yourself and ask Anna the question?
Thank you, Anna. You mentioned about the thrombocytopenia. How important is that when you have a patient referred with thrombocytopenia and they think that could have,
so
cancer?
It's thrombocytosis, so high platelets.
Sorry, thrombocytosis.
Yeah.
Yes. Sorry.
And it's to the NICE guidelines are women over 55, and it's not just thrombocytosis; it's in the combination with hematuria and vaginal discharge. So if you're getting that collection of symptoms, that's where NICE say to do a pelvic ultrasound scan in primary care. But it's not in isolation, so you wouldn't just investigate for just thrombocytosis. Yeah.
Thank you.
Okay, great. And then maybe one more question, if that's okay. So Akila, did you want to ask your question?
Yes, please. I just want to clarify about women with high BMI, and we are offering fertility sparing treatment because they want to have a child, and early endometrial cancer. I missed that slide, half of it. Like I saw that you biopsy 3, 6, and 12. Let's assume that's normal, or it's reverting. Because I have a couple of women who's not yet conceived, but it's negative, and how far do we wait? That's one thing. And then also the other woman has already started asking me about having one more child.
So with any fertility sparing approach, this needs to be really targeted to the individual, and I think you need to work really closely between the fertility team and the fertility consultants and the gynae oncology MDT. And what I would say in that context is that sometimes there can be quite short windows for conceiving, and you do need to look at a woman's overall risk. So if they're very obese, they've got a much higher risk of endometrial cancer and progression, and weight control and things like rapid referral for bariatric surgery can be considered. But if you you need to look at the impact of that on their fertility as well. So what I would say is that's going to be a really careful discussion through MDT with input from the fertility team, and it would need to be kind of individualized. And the woman really needs to understand what the likely outcomes are. So, you've got a 25% generally live birth rate. That may be less in a woman with other risk factors like obesity. So I think trying to individualize your counselling there would be important.
Okay. Sorry.
I think there's Maid. Do you want to ask a question, Maid, and then will that be the last one? We're going to be.
Thank you.
Maid, do you want to turn your camera on?
Yeah, I'm trying to work on that actually. There it is. Hi, Swimi.
Nice
hi,
to see you after a long time, Maid.
I know. To think I was once in your shoes, Anna, about just under a decade ago. So
fantastic. Your question, Maid.
See a lot of products. So the question is, so in terms of the treatment with medroxyprogesterone, is there any benefit of oral versus putting a merino coil in? Because speaking to a few colleagues, some would say that the use of a merino coil in the conservative management doesn't give you as much result as oral progesterone. Yeah, I'm done speaking.
I mean, I'd say from a personal experience, I think you can adjust the dose of the progesterone. You can use a much higher dose. So when we use the Myrene, often we use it for atypia or low-grade cancers. But sometimes in the cases where we've had advanced disease and patients often bleed heavily, we've increased the dose to 200 plus, twice a day. So you can titrate the dose more and you can give a higher dose. That's the only benefit I would say, unless other colleagues have any other comments. Susie, did you want to add anything, or Anna? Okay.
Yeah, I'd just say patient risk profile as well. So obviously very high doses increase your risk of thrombosis. So I guess if there's kind of additional risk factors for that, that might be a consideration.